unmute and ask me about whatever you would like. This is not like any kind of formal teaching. It's just a focused study group, as I prefer to say that. Okay, so let's go ahead. So today's case is a 47 years old male who was recently referred to the MS clinic. MS neuroinflammatory clinics is not particularly, the question has been raised if this is something that belongs to the neuroinflammatory conditions, and subsequently has been referred to us. So it's that's a left side numbness over he suffered this left-sided numbness, an episode of acute left-sided numbness over the last months. Initially, he has been referred to the general neurology service and later on referred to the specialized MS practice. He has a background history of hypertension, obstructive sleep apnea, depression with what seems to be some psychotic features, but however, this has been well controlled on treatment. So back to the focused history. So pardon me for the mistake of writing right heminumbness. This is a left heminumbness. So it's a left heminumbness that was including the face. There was no particular weakness and no previous similar episodes. The rest of the history doesn't seem to be provoking for any other ideas. He had a normal balance, no headaches, apart from his other medical conditions. Neurology was not a concern at that point. And his examination was also normal, apart from evidence of some long tract signs. So he had a normal fundus. His cranial nerve examination has been unremarkable. His sensory examination, by the time you start to see him, is almost a month after his presentation, is now gone. But he showed some signs, some pyramidal signs, actually an equivocal plantar, right plantar, and an increased deep tendon reflexes. Okay, so and based on the initial assessment, the team initially was under the impression that it might be related to a cerebrovascular disease, and later on, this was suggested not to be the case and has been referred to your attention. I'm going to share first the FLAIR images. Then we were going to discuss. I'm not going to comment on that at this stage, but let's have just time for you guys to have a look at the scans, and then we can proceed after that. So that's the way I prefer to view the FLAIR, axial FLAIR. So I'll start with a bit the very top part of the brain above the lateral ventricles, the frontoparietal region. Still frontoparietal until the moment you start to see the hippocampus and the lateral ventricles. That's still frontoparietal, and then starts the frontotemporal region. That's the inferior temporal, anterior temporal, and upper brainstem, of course. Now mid pons, low pons. Sorry, upper pons, and then mid pons, cerebellum, and the lower brainstem, and the inferior cerebellum as well. Okay, so that's his FLAIR, and that's his diffusion scan. Apparently, the not finding an acute or subacute infarction here was disappointing to the general neurology service. His MRA as well was non-revealing, and to that point, yeah, so it was non-conclusive with what looks to be white matter disease. And let's start with the common basic sense questions. So what do you think? Do you think the raising a suspicion of a neuroinflammatory of a white matter, or multiple sclerosis in particular, how do you think you would justify that? Do you think this is a reasonable differential here? Feel free to just unmute and speak out, or if you would like to text me, that should be fine as well. So who would agree that this is at least a possible MS, or based on the FLAIR scan? So I got in the comments, Dr. Diane has mentioned PML. That's one potential differential because this is a white matter disease burden. However, PML tends to be symptomatic, tends to have a particular diffusion weighted changes, but however, they are not there, but they can. This again, this is one of the possibilities. But in PML comes with its own risk factors. He's 47 years, and he has no other risk factors so far. Small vessel disease. Why not? Why not? He's hypertensive and obstructive sleep apnea patient, and however, it is a bit early for his age. He's only 47, but that's another good. Yeah, white matter ischemia. That's another differential coming on. Okay, but why? Let's provoke the question. So why this is MS or why this is not MS? The problem with multiple sclerosis or any given white matter pathology is that it is over time when the lesions becomes confluent, it's very difficult to tell. It's very difficult to tell. So when there is very, very little lesions, or when there are too many lesions in a white matter, it's very difficult to say. Okay, so Dr. Dan has mentioned not MS. Okay, morphologically not applicable to MS. Okay, let's talk a little bit about that. Yeah, thanks for raising the question. Is there any red flag in stating MS here? Based on a flare, so it's based solely on the flare. So let's go through the description. So let's have a little bit of a deeper description to the scans here. So overall, so this, if you would like to state it in one statement, this is a confluent, multiple, extensive white matter lesions primarily involving the periventricular region, extending to some extent to the juxtacortical region, juxtacortical compartment, as you can see here. And Dr. Raffat mentioned sagittal flare is needed, which I absolutely agree. Yeah, I don't have sagittal flare here, but it would be really helpful to have that as well. So there is no the disease is primarily a supratentorial disease so far, with no involvement to the brainstem, with no involvement to the cerebellum so far, and it is heavily involving the frontal and the parietal regions relative to the temporal lobe. So that's what we can conclude. There is a bit of involvement to the temporal lobe, but here, if you can compare the anterior temporal lobes here to the top of the frontoparietal region, that says unfair distribution of lesions. So the lesions are predominantly in the frontoparietal region, and to a lesser extent to the temporal lobe. Okay, another differential comes in the chat carousel. That's another important one. Actually, it is as a matter of fact, white matter space is a large football pitch that all the neurology teams comes to play at. So it says white matter pathology. If you would like to list the white matter pathology and the possible conditions that can cause that. The list is quite exhaustive. It's literally everything. Carousel is another good example as well. PML is another. Cerebral small vessel disease is another. Multiple sclerosis is actually has been raised already, and the case has been deferred for this condition anyway. So by far, this is a gross description. So let's take a little bit of a deeper description to the lesions. Let's go to describe if it is touching, is there any cortical involvement or not. So a little bit up to the top, towards the top. So there is no, the lesions comes in close proximity to the, this is, for example, this is superior frontal gyrus, but, and again, this is the middle frontal gyrus, and you can see lesions are quite close to it. However, the cortical ribbon is spared. Importantly, in this situation, you would like to make sure that this is just a brain parenchyma, so the whole meninges doesn't appear to be involved. So spanning top to down, this next step in evaluating this scan, from top downwards, I would go through span with my eyes, and I want you to do that through the cortical ribbon and through the meninges, the meningeal coverings, the left two meninges and the dura as well. So here, this doesn't look, so far, doesn't look to be the case. There is a form of involvement to the cortex or to the leptomeninges, subarachnoid space. Again, this looks all right. Yeah, and I'll go a little bit faster here. So this is how the dura, I wonder if you can see this very little hyperintense rim here. This is a dural covering, and usually the leptomeninges spans up and down across the sulci and gyri. So, but they look spared. They are all right. So this is a parenchymal disease. So particularly when you don't have a diagnosis, it is very important to rule in or out the involvement of the additional tissue. If you have an involvement to a cranial nerve, if you have an involvement to the CSF space, to the leptomeninges, your differential dramatically changes. So, and of course, drifts away from MS anyway. But okay, so in any case, that's appears to be a parenchymal white matter spreading to two compartments of the MS, common MS compartments, the juxtacortical. It touches the cortex, but it is not heavily involved in the cortex, and it is predominantly in the frontoparietal region, deep white matter, periventricular predominantly, sparing the posterior fossa. Now let's have a little bit of focus on the orientation of lesions. The problem here is that when the lesions are confluent, it's difficult to tell if what type of pathology is it. But you can see overall, you can see a nice outline here, a nice outline here. Something you can see with MS, and something you can see with inflammatory conditions is that you can have an outlined, well outlined lesions. Some other lesion, predominantly small vessel disease type, they usually come up with a fluffy border like the small one here. So that's a mixture of well-defined lesions. I think some of the lesions, if you notice, there are some hypo-intensity within these lesions here, around the lesions. Can anyone guess what these hypo-intensities are? Virchow, yeah, Virchow-Robin spaces. That's absolutely correct. This is dilated Virchow-Robin spaces, and what runs in the Virchow-Robin spaces are vessels, and the vessels include arteries and veins. So these lesions runs around the blood vessels. So this is, if you can see, this is a tiny vein running here, or dilated Virchow-Robin spaces. Regardless, the lesions tends to be around the veins or around the arteries anyway. So it's around the perivascular spaces. Again, here and there and there. If you see, this is a tiny bit of hypointensity of perivascular space, and there are some lesions around it. So this comes a little bit tricky now, because this is a pathology around the space, or around an artery, or around the vein. So, which is one of the signs. Actually, this is one of the signs for MS. Again, this is a radially oriented perivascular space, and again, the lesions extend through them. And this is another, this is a vein or a vascular space that spreads up, down, and this is a cross section to it, and this is another lesion surrounding it. So now the lesions becomes tricky because you can never tell. So these are very perivascular spaces that don't have lesions around. They look thickened around them, but they are not particularly involved, which is something you would expect if this is a hypertensive small vessel disease. So if it is a hypertensive small vessel disease, likely you will involve the basal ganglia at some point. This is not. So this pathology has, despite having multiple dilated vertebral spaces or perivascular spaces, and you don't have this involvement as heavy as it is in the deep white matter. So it is not, at least it maybe raises suspicion that this is not the classical small vessel disease. Okay, temporal lobe involvement is somehow it involves to a lesser extent, which is something you would expect with vascular pathologies for one good reason. The temporal lobe has a little bit of good anastomosis or a good perfusion compared to the frontal and parietal lobe, because it is in close proximity to the skull base, and it has bilateral supply from the posterior circulation of PCA, anterior circulation of the middle cerebral artery. So it is rarely involved in small vessel disease. It can be involved, but it is involved later in the disease. And again, this is a feature that happens with small vessel disease, features that happen with migraine changes. So when you find a pathology, a predominant pathology in the frontal and the parietal lobe, you are more into thinking of small vessel disease or non-specific migraine changes. If you find the other way around, you are definitely not into this category. You would like to think of carousel, for example, but that's not the case. Our case here, because the temporal lobe should be spared, there is no prominent history of headache. And you would like to think of multiple sclerosis. Well, multiple sclerosis is frequently involving the temporal lobe and doesn't follow any vascular perfusion related patterns. So this interesting lack of predominance of the temporal lobe is another thing you would like to consider. And also the posterior fossa is completely spared. Something that is weird with many conditions. MS usually will involve at some point. Even small vessel disease, even if it's predominantly an anterior circulation, you would like to, you may want to see some changes there. Okay, so that's my comment on the scan so far. But let's swap to the important bit about our teaching here. What you would like to revisit in the history and examination based on that scan. Will there be any specific thing you would like to ask about based on what you have found on the MRI? Good. Any previous attacks? Yes, that's absolutely makes sense. Yeah, because maybe we can fulfill dissemination in space in time if that's like an MS case. And by the way, it is my final comment about the white matter lesions there, that they can be MS, but there is nothing specific about MS there. Migraine and cognitive symptoms. Yes, I thank you. I would like to revisit that, even if it has been like completely, or at least mentioned, even like briefly in the history, that there is no history of headache, but you would like to visit that one more time. There was a history of depression with psychotic symptoms compared to cognitive symptoms, but this is something I would like to take into consideration. Yes, yes, thank you. Anything else? In the examination, would you like to examine something else? I would like to assess him from a cognitive point of view. I would like to see how he's performing. Okay, Dr. Ziad is mentioned something about sphincter disturbance. Very well thought of, because if it is a small vessel disease, building small vessel disease, you would like to think of few potential of that. Skin and joints, this is something to point to connective tissue disease. Yes, that's absolutely something you would like to look for. Yeah, thank you. That's a reasonable way of thinking. That's a first bet. The next bet is what you would like to investigate or to do next based on that scan. So what you would like to include in your workup. So I've seen that, you have seen the patients, you've seen the scan. What's your next step? So I would like you to imagine yourself, you are an MS specialist and you have been offered this case and the question is raised to you, is this MS or not? Would you be able to, is the available information, just is enough for you to say that this is not MS or this is suspicious for MS and I would like to go further. The challenging bet with this case is that you don't have enough evidence to rule out. And definitely you don't have enough evidence to rule in, because if it is like white matter pathology, that it is juxtacoated and periventricular, this is 2/3 the neurology textbook. So that's not something that you can rely upon. So Dr. Rafat has mentioned something about CSAF and OCBs, which is a very, very, very fair thing to do. Yeah. And Dr. Ziad is mentioning about MRI of the spine, because the patient had pyramidal signs, and why not? Enough from the cerebral hemispheres to have pyramidal signs, but yes, vasculitic screen is important here as well. And thank you so much for the contrast, because if you, for example, if you found a few lesions with a contrast enhancement here, that's definitely not an early hypertensive small vessel disease. This is a dead end to this potential diagnosis. So you would like to investigate the potential for a vasculitis, for MS, even for whatever can happen, or whatever can happen that is particularly breaking or breaching the blood-brain barrier. So that's contrast is really important. Yeah, thank you for that. Anything else? JC virus for PML? What do you think? Are you thinking of any potential infection that might contribute to that? Yeah, virus screening is important, but particularly HIV. So because it is one of the common conditions or the known conditions to involve the white matter extensively. So it is, despite that this looks like to us like a vasculopathy of something, or in the discussion is on inflammatory side, but HIV is important to rule out anyway. So you would like to include that. I would keep the JC virus testing as a second tier step, particularly because the clinical presentation and the risk factors does not point to it. But however, at some point it needs to be done anyway. And yeah, Dr. Ziad is mentioning VDRL. Syphilis is one of the things that might. Yeah, why not? Why not? I would include them all. Yeah, good. And Dr. Hind is mentioning EBV. EBV is not. Yeah, why not? But however, just speaking of prevalence, EBV is something that we all had at a point in time. And the prevalence is 90% in the population. Might be a recent one. However, you would like to think again about risk of acquiring a CNS infection that is as an EBV. In this case, CSAF is double important, not just for the CSAF, it's also for looking for cells and looking for evidence of infection. So his autoimmune screen negative, his virology workup has been negative as well. His CSAF examination was acellular, no cells and no bands. That's his neck. A cervical MRI examination was done. Didn't span the whole spinal cord, but enough to say that's a stir sequence and that's normal. I don't have the post-contrast scan, but the post-contrast has been okay. The post-contrast did not show any enhancement. Are you missing any other sequence you would like to have? Or any other workup you would like to add? Okay. I think you mentioned you mean if they are as sweet or smart. Okay. Uh, okay, yeah, that's absolutely important. So this particular MRI scan is not complete. And the teaching point I would like to discuss with you today is that you need to have a full assessment for whatever MRI scan you have for a particularly undiagnosed condition. Um, so it had a diffusion, we had a flare, we had a post contrast, we had an MRA, but we didn't had a blood sensitive sequence. Yes, that's correct. And we need to look for blood products with a blood sensitive sequence, because it can completely change our direction for our diagnostic workup. So what are the sequences that are blood sensitive? So it's the T2 star, gradient echo, or a susceptibility weighted images. Short of is called SWI, SWI. And here is his gradient echo. Would anyone like to mention what exactly are these lesions or these findings? These are microbleeds. These are, yeah, these are multiple hypointense rounded lesions. That's absolutely correct. But these are called microbleeds, cerebral microbleeds. So this is an artifact, by the way. So the size of this hypo intensity is not real, is not the real size of the lesion here in the brain. So this particular lesion is significantly, is likely of the same shape, uh, but it is a little bit smaller than what it appears on a gradient echo or an SWI. And because the lesion gets bigger on this sequence and it gets more visible, this is called blooming. Blooming means the opening up of a flower. So when the flower is closed, if you can imagine, the lesion is not occupying much space in the actual anatomy, and on a blood sensitive sequence, it blooms, it opens up, so it appears much wider and bigger than it should be. So there are multiple cerebral microbleeds involving juxtacortical regions in nearly all the brain loops, different brain loops. There are few in the frontal lobe, few in the parietal. As we go on, there are deep basal ganglia and thalamus microbleeds as well. Temporal lobe is to some extent involved, matching the white matter lesions, but is still involved. Occipital lobe is involved as well. And there are some relative sparing to the posterior fossa as well, but however, that is the case. So I think to this point, even when you had a negative bands, your no against MS is still weak, or at least it's not as strong as this particular sequence. Once you had a cerebral microbleed, this is a no-go for MS. So that's definitely not. And this is a vascular pathology, full stop. This is something related to the blood vessels rather than to other inflammatory conditions. So it's not our list of inflammatory conditions and the full list of white matter, confluent white matter lesions shrunk once you had a gradient echo. And this is the real importance of that you have this particular sequence. You have a blood sensitive sequence in your new patients. So as a routine to your full MRI examination. Okay, so I'm going to go through the potential differential of a patient. If you have a patient with few white matter lesions, too many white matter lesions, and you found lots of cerebral microbleeds, what are the possibilities? First and most important is a cerebral amyloid angiopathy. Our patient is a little bit younger age. But however, some people with inherited conditions or inherited genetic tendencies, or they have a higher risk of developing CAA or cerebral amyloid angiopathy, such as people with ApoE4 abnormalities, people with pre-synaptic abnormalities as well. So there are some genetic conditions that might have an accelerated cerebral amyloid angiopathy, and even in the 47 years is something that you would like to consider. There is a criterion based on a combination between the pathology and the MRI findings that can help you to make a diagnosis of CAA, which is cerebral amyloid angiopathy, or not. Our patient, our example, is not a good example of CAA. Based on Boston criteria, because Boston criteria requires you to make a diagnosis. If you would like to make a diagnosis based only on the scans, you would need to have a strictly lobar microbleed. So our case had a deep basal ganglionic microbleed, so that checks against a diagnosis based on the MRI. And the patient needs to be above 50 years of age. So it doesn't fit into CAA. For this patient to make a diagnosis, it's likely that you might have to get a biopsy to get this done. Any case, sometimes the biopsy are made not like, for example, if the patient presenting was just simply hemisensory symptoms, but some people present really with frank hemorrhage, and they would like to evacuate the hematoma, get some biopsy while evacuating the hematoma, particularly if it is lower, and you get a firm diagnosis. So that's even if the patient had basal ganglionic changes, and he's young, you can have a CAA diagnosis, of course, based on a biopsy. Next comes to the list, thanks to I think